Hello, I'm Dr. Bolanle, your host on the Bright Minds MD and your mental health podcast. Here, we discuss topics designed to explore the full spectrum of mental well-being. You'll hear from experts and listen to personal experiences that inspire and inform. So, whether you're seeking insights, solutions, or just a dose of motivation, this podcast is your perfect companion. Hit that subscribe button and join us on this incredible journey to mental well-being. Your whole health starts with your whole mind. Let's get started. All right. Wow. Hello, everyone. This is Dr. Bolanle Akinranbi, psychiatrist at Bright Minds MD, psychiatric practice in New Jersey, where we help people who are worried and anxious get well and find healing and calm. I'm super excited today about the topic, especially that we will be discussing today. With me today, I have Dr. Ed Wang, founder and OB-GYN at Lifetime Women's Health, an OB-GYN practice in Suffolk, Virginia, with a focus on general practice, but especially focusing on disorders of the menstrual cycle, especially bleeding. Welcome, Dr. Wang.
Good morning.
Good morning. Today, I'm really excited to be talking with Dr. Wang because OB-GYN and psychiatry have major overlap that is often not talked about. And so I do a lot of referrals to OB-GYN in my psychiatric practice for a topic that's very well familiar probably to a lot of women for anemia, especially. So I'm hoping and looking forward today to talking with Dr. Wang about the intersection of periods, bleeding, anemia, and how, what's the connection between mental health and, gynecology and all of that together today. Dr. Wang, would you like to open up and speak on that today?
Sure. I think one of the things that, is important to recognize is that, menstrual disorders, heavy bleeding is actually very common. And it's estimated that somewhere around 30% of the population of women actually experience, heavy bleeding menstrual cycles during their lifetime. And I think this is I don't have a specific statistic for it. But I would say that, that incidence increases as you get older. And, one of the things that we see a lot of times, kind of different subsets of patients who have the bleeding problem. There's young patients who kind of, unfortunately, start out with their menstrual cycle being heavy, from teen years. And then there's another subgroup that have normal periods for many years, decades even. And then when they reach the perimenopausal period of their lives, or that time, in the late 30s, early 40s, where the hormones in the body start to change, many of them start to experience that heavy bleeding at that particular time. And so, I deal with both types of patients, but we have at our office just a heart for the women who are in their 30s and 40s who experience this problem.
Interesting that you mentioned that the 30s and 40s are very, I think for a lot of, especially professional women these days, those are the mom years. And in my practice, that's when women present to me and they are having trouble juggling their professional careers, their jobs, and also maybe moms, if they are moms, as well as maybe if they have a partner marriage. And so when I see them, this age group of women, they are tired, they're fatigued, they're depressed, they don't have any energy, they don't want to have any interest in doing anything. They're not enjoying life. They feel like they're dragging on. And that's when they present to me, often saying, I'm feeling very depressed. I don't enjoy life. I can't keep going like this. That's when they see them, because then the demands on them are so much. And oftentimes, right, when then we do the evaluation, as part of my initial evaluation as a psychiatrist, I would often obtain blood work. And surprise, surprise, oftentimes I find like anemia, in the interview they talk, maybe we might find out they're having like heavy menstrual periods, they're soaking a lot of tampons plus plaids. Maybe that's happened for them to them for many years. They've never paid attention to it as much, and then suddenly like life burdens and life demands are increased, and they're appearing to have depression when they come in my office. And then we uncover this anemia, we talk more, we know that something relating to heavy bleed is there, and this is when I refer them out to an OB-GYN for and sometimes a hematologist for additional discussion on what can be done about it. Because I know that no matter how much I try to treat this with an antidepressant, it doesn't go away unless we address the anemia. So what do you see when they come to you? I don't know if you get referrals from psychiatrists, Dr. Wing, or if these women also just not call you because they're having heavy bleeds. And what do you see on your end as an OB-GYN from this bleeding women?
I definitely, note the same thing about the anemia. And I have a saying that I give to a lot of the patients, where I say, there's a hole in the bucket, and unless you do something to patch that hole, you'll never be able to fill the bucket.
Absolutely.
And so, the struggle is that oftentimes women, are taking treatments for the anemia, but the anemia won't effectively get better because every month, or sometimes multiple times a month, they have these bleeding cycles that just decreases it back down again. And it's kind of like chasing the wind, you just can't catch it.
Water in a basket. What causes these bleeding disorders anyway?
Yeah, there's a lot of different things. It would be a long discussion for us to talk about all of them, but I'll mention they kind of fall into a couple of different areas. One is hormonal type imbalances, and hormones. There are hormones that are produced by the female system, the ovaries, and also by the pituitary gland that directly control the periods. And then there are other things like, for instance, the thyroid, which can have a profound effect on how a woman experiences her periods. Then there are problems with the uterus itself.
Okay.
Fibroids are a very common thing, especially in African American women. There can be 25% incidence of fibroids in African American women. So 1 of 4 has fibroids at some point.
It's pretty high.
Yeah, and not all of them are recognized. Some of them, can be small fibroids, but there are many that have bleeding problems because of those fibroids. Problems associated with the uterus that can cause that bleeding. And then more concerning things. There's the cancers that arise that can cause the heavy bleeding. And then finally, sometimes it doesn't have to do with the female structures at all. Sometimes there can be a problem with the way that the blood coagulates or clots.
Okay.
And that can be a hereditary condition that women don't realize that they have until we do an evaluation for heavy bleeding, and we discover that.
Interesting. So the blood category. Oh, I'm sorry. It sounds like you had another.
Yeah, just one more.
One more.
Certain medications can cause it as well. So
Okay.
the easiest one is the blood thinners used for like blood clots in the legs or lungs.
So the aspirins, even.
Yeah, not so much aspirin, but the aspirin can affect it. But there's many different classes,
Right.
of medications that can cause that. But the blood thinners, anticoagulants are the most, one of the most common causes.
Interesting. Just to summarize that for everyone listening, so the broad categories of things that can cause bleeding problems are the hormones. We mentioned the pituitary and the thyroid hormones. We talked about structural problems and highlighted the fibroids. We talked about cancers. And we also talked about medications such as, anticoagulants being like the bigger culprits in that group. Does that kind of summarize at least the major categories that people can think about when they're thinking about their bleeding problems?
Pretty much.
Okay.
Pretty much.
So does that change how you work them up when they come to you? What do you do for them? So a lot of women ask me when I start telling them we got to talk to the OB-GYN, they start telling me I want to test all my hormones, and I know that this is a very non-specific, vague request to have from a patient. So what do you do when they come to you? What do you do for these women?
One of the things, and I think this is something that you and I would share. One of the first things that I do is I find out how is this bleeding affecting their lives? What happens? I was watching a it was a TikTok video the other day, and it was a video of a woman who had heavy periods and the preparation that she went through to go to sleep at night. And it involved putting multiple towels on the bed, preparing, pads in her underwear so that it wouldn't leak out, having some kind of heating pad, that she slept with, and making a schedule to get up in the middle of the night to check on the bleeding to make sure it hadn't. And, as I saw this thing, I said, oh my gosh, how horrible to have to live that way.
It is. And I'll give you a personal story, Dr. Wing. I don't think I told you this when we spoke, but I suffered with endometriosis for many years, and that involved a lot of bleeding. And life was planned around the bleeding. Life was planned, travels usually don't happen at bleeding weeks. Things have to be packed, no heavy workload, plan for a light workload, potential to have to take off. A lot of things that just is built around that people have to do who have bleeding problems. So personally also I have, personal experience with this, which is why I'm so vigilant for this as an issue. I suffered with anemia for many years until probably after my second child, before I figured out a solution that really took care of things, at least for now, for me. So this is something I'm so vigilant about because of my own personal experience as well. But yes, heavy bleeding is very life altering and life impacting for a lot of women. And by the time they're talking to me, they're bleeding so heavy. I people are walking around with 7.5s and 8s of hemoglobin when I'm seeing them, and by the time I'm seeing them, they're already tired, they're frustrated, they're probably very irritable because they're running on fumes. They're feeling depressed because they cannot keep up with their lives. So in one part, on the mental health part, that's a big impact as well. That is not often talked about. So how do you
I think there's just a lot of other things that, kind of affect that as well. One of the things, and I'm sure that, as there are patients from your practice or that listen to this live that will be able to relate to this. When you have problems with your periods, and some women have problems that they cannot predict when their periods are going to come. Yeah. It's just, so they have to be ready, for it all the time. It's kind of hard to have a love life with that.
Absolutely.
It's kind of hard. And many times the relationships that these patients have with their partners is very strained.
Right.
Because they're having this, and it's just it's miserable. The way that they relate to their family, the way that they relate to their coworkers, their friends, is all affected by it, which, gets into a cycle of stress and a cycle of, just problems because of those relationships being strained, by this.
Absolutely.
And one of the things I'm sure that people who have the problem know about this, is the financial aspects, of this problem. I have patients that when their cycle comes along, they have to call out from work.
Yeah.
They can't go there. And many of them lose jobs because of that.
Right.
They,
You can only call out so much.
Yeah. Or, how about the fact that, the cost of feminine products to control those periods. Pads, tampons, those things, they're very expensive.
Absolutely.
And when you're going through, boxes and, I had a patient that, made me aware that she had to keep feminine products in basically every life space that
100%. I know this too well, Dr. Wing. 100%. Every purse, every car, every corner, drawer in the office, closet, anywhere. Absolutely. It's a very expensive undertaking.
It is.
So how do you work them up when they come to you? So that's a historical piece, finding out about the life impact. But what do you do for them in terms of workup? Are there imaging labs? What do you look for?
Yes. So it's kind of a comprehensive way that it's done to kind of rule out all of those different causes. So the first thing is a history and a physical exam. We do things because we have a specific clinic for this. It's kind of condensed into a very, very short period of time. It's not something that takes months and months for us to come up with a idea of what's causing it and come up with a plan.
Because this is what you focus on. You have a protocol thing to do, big things to get people through it.
We've set up a clinic for this.
Okay.
And so, the first would be the history and the examination to really, kind of understand a little bit of what are the nuances of this particular patient's story. Okay. And that usually will, point us in certain directions. We do a general set of blood tests, which look at all the different hormones, which look at the degree of anemia. Back in the history, we take a look at the medications that they're on to see if there's any particular ones that can be affecting, the periods.
Okay. Any imaging?
Yes, and usually we use ultrasound.
Okay.
Is our main.
Is this done in office, or you have to send them out typically?
It's done in our office. We have an ultrasound unit in our office.
So this is looking for the structural piece of it, I imagine.
Yes. Okay. And then depending on what we find, technology is wonderful. Back when I was in training, if we needed to do something to assess the inside of the uterus, we'd have to take them to the operating room to do that. But one of the things that we have now is what's called a hysteroscope.
Okay.
And it's a small telescope that we can place into the uterus and actually look around inside the uterus. We can look at the lining of the uterus and get an idea of whether it appears normal or not.
This can be done in the office?
In the office. No anesthesia.
Wow.
And the instruments are very small. So if I can give you an idea of the diameter of the hysteroscope that we use, if you can think of, if you've had one of those types of pens that has the little refill on the inside of it, that little, part that actually holds the ink in the pen, it's a little bit bigger than that.
Oh, wow.
So it's very small.
Yeah.
But it has a light source on it, and it's attached to a camera. And so we can actually see inside. Most patients tolerate it very, very well in the office. And it gives us a whole lot of, information. We can take samples of the lining of the uterus and send it for evaluation. We can see if there's any polyps or fibroids on the inside. So that's something, not all patients get that, but some definitely do.
Can the repairs be done right there and then, like looking, or then if you find something that needs repair, like or cut out, do you then have to, is that a next step?
So that instrument, because it's very small, it's limited in the operative things that it can do. There are instruments that I can put through it for taking like biopsies, or if there are small polyps, I can remove those in the office. But if there was something bigger, then that would be something that we would have to take the patient to the operating room.
So looking at the broad categories, and thank you for sharing that, Dr. Wang, that I think is very informative for people who are listening. Again, the general public who wants to know, what do I do if this is, because of my bleeding, and maybe if this is part of why I'm feeling depressed, what do I do? It sounds like looking at the main causes. We talked about hormones, so you do the hormone panel to investigate that. If we're looking at structural stuff, you're doing this imaging exam in office to look around and see, if there, what's happening in the lining. Are there any, structural problems, masses and things that is contributing to this problem? And then from the, and then medications, of course, that you look at in historical conversation, taking history and being able to make recommendations on that. So after looking at all of these and finding out, pinpointing what the problem is, what do you do? What's the recommendations? What are the interventions after? And it seems obvious, but I just wanted you to touch on it a little bit.
Yeah, the one thing that I am very key on is to recognize that each patient has their own values and their own willingness to participate in a treatment.
True.
And this is going to be, in many cases, a long-term treatment. Now, we look at the onset of menopause as kind of the end of it all, because when menopause happens, the periods go away, and then this isn't so much an issue anymore. But if you're 38 years old, the average age of menopause is 51, so you have a long time to go.
Right.
So we try to take all of those things into account. Also, one very big question is, does the patient want to become pregnant again? Because if the patient wants to become pregnant again, that's a different conversation than somebody who's like, no, I have 3 children already. I am done with children. My husband had a vasectomy. I had my tubes tied, or whatever it is.
We're good.
Those conversations are very, very different.
So what can you highlight for me a little bit, and for some of our listeners, some of the potential interventions you might think about or might want to discuss with them, depending on what you find?
Yeah, so one of the things that the treatments come into 3 main categories. One is conservative treatments.
Okay.
It's cold in Virginia.
Oh boy.
It's conservative treatments, and so there are some women who they have heavy periods, but their anemia isn't too bad, and they've kind of learned to deal with their periods, and they don't really want to have active, I won't say that's the wrong word to use, but more traditional medicinal or surgical treatments for it. And one of the things that we can do is we can look at diet and how that can affect the periods. We can look at how the patient's weight affects the periods. One of the things that I didn't mention it, but it would fall into the category of hormone imbalances, is the polycystic ovarian syndrome.
Oh, that's
very
big.
common, disorder that women have. That it is a vicious cycle. It causes weight gain and obesity,
Yes.
and then obesity makes the syndrome worse.
Yeah.
And so it's a vicious cycle that just goes around. But if you break the cycle and reverse it by losing weight and exercising more and being more active and watching your diet, especially your carbohydrate intake, and seeing the doctor, making sure that you don't have diabetes, sometimes using medications to treat diabetes, all of these things can have an effect on you. So that's a more conservative
approach.
Like that. And then, of course, following up with me on very regular, intervals to see the progress of that.
Okay. So on that conservative end for something like PCOS, it's more, a lot of interventions you mentioned are things that patients will be in charge of doing for themselves, right? The diet, the exercise, the maybe following up with the doctor about the, I guess, insulin resistance or pre-diabetes or diabetes, depending on where they are on the spectrum. Would hormonal treatments be part of the consideration for them? I know that OCPs are part of this conversation.
Absolutely. And, one of the most common things is to use the birth control pills. That is probably the most common treatment for heavy bleeding. There are different types of hormonal medications that can be used as well. The injection, Depo-Provera, can be used. I don't like to use that one as a primary one because it can often have the opposite effect. It can cause you to have more bleeding that's not predictable. But in some women, it makes the period go away altogether. And somewhere in between a medication and a procedure are the IUDs that contain hormone that's built into the IUD, and that IUD is placed inside the uterus and then releases that hormone over the lifetime of the IUD, which that one particular one is 7 years, and that hormone release is very local. It gets into the body, but at very, very small amounts. But locally, it causes the lining of the uterus to get very thin. And in many women, it either makes the periods much lighter or it can make the periods go away altogether. And so, we're not using it primarily for contraceptive purposes, but for treatment of the heavy bleeding. And so those are the main medical treatments. There are also some other medications that aren't hormonal. Racemic acid is one of them that comes to mind. And that's a monthly medication used at the time of the periods to have an effect on the amount of blood that's released during the period. And then there are some treatments for fibroids, which can help with that.
Wow. So what I'm hearing is that there are lots of options for patients to consider, which makes this trip to come discuss with the OB-GYN really important to really see where are you, what are your childbearing or future plans, where are you on that childbearing pathway if it's a thing you're thinking about, as well as then to figure out what options would be right for you, whether it be hormonal treatments, non-hormonal treatments, method of delivery, pills versus IUD, and I think we talked about the depots as well, the pros and cons of it. And I think surgeries we kind of touched on a little bit, but didn't really get into.
So the surgeries, are something that I guess there's different types of surgeries too. There's surgeries that are, uterus preserving, and so we had talked about the hysteroscopy, and if there's a particular mass or something that's inside the uterus, then surgically we can go to the operating room and remove those masses, which is wonderful. In these days, it's an outpatient procedure in most cases. You come in, you get the procedure done, you go back home. You don't have to stay in the hospital. There's something that's called endometrial ablation, and that's a procedure where we use a very high-tech device that we place into the uterus, and what it does is it actually destroys the lining of the uterus with heat, and it's very computerized. It monitors the process. It only allows the heating to go a certain amount so that just the lining of the uterus is burned, not the
will this be so when you're burning
itself.
the lining of the uterus, does it then grow back, or how does this play into someone who plans to have children in the future, for example? Is that done?
Yeah. So this is done in a woman who is not going to have babies in the
Okay.
future. As a matter of fact, that's a contraindication. If you want to get pregnant, that's not the procedure for you. So, and for me, I really would use something really, that we can be confident that they're not going to get pregnant, because a pregnancy after a endometrial ablation can be life-threatening.
Important to note.
And so,
okay,
yes. And then finally, there's if there's fibroids, the fibroids can be removed through a surgical procedure, and then ultimately the most definitive, where I can tell the patient 100% they're not going to have any more periods,
take it all out,
is a hysterectomy. And I think I'll mention some things about the hysterectomy. Many times my patients don't want to come to get evaluated for the heavy bleeding because they have the wrong idea from family members or from the media, social media, that hysterectomy is the only thing that they can do. And so they stay and they suffer and, just put up with it because there's this, decision that they've made that they don't want a hysterectomy. And so they think that that's, all we have to offer.
I think that's super important to highlight that, because we talked about so many options before we ever got all the way to the hysterectomy at the end. So many options to consider.
And I think it's actually interesting because, sometimes the patient will tell me that right from the beginning, that they don't want a hysterectomy. And I hear that. And, but many times with patients, I will tell them as the first thing, okay, we're going to talk about treatment options. And I'm going to just say right from the beginning, I think we have lots of treatment options that we can do that don't involve hysterectomy. So let's just take that off the table right now. And, the freeing that happens by just doing that, where it's almost like a relief for many patients. And then I have some patients that are like, what? I want a hysterectomy.
Different strokes, right?
I'm like, okay, well, we could talk about that too, but I want to let you know at least of the other treatments first. And then, if you decide after that you want to have a hysterectomy.
And I think that's what a lot of patients, a lot of people want. Because many people feel like, I'm going to go to the doctor and they're going to tell me that this is what I have to do. And mostly now, in medicine and healthcare, it's joint decision kind of model. We educate, we give options, we put it all out on the table. And then based on where you are in life, what your circumstances are, and and your doctor's advice, together you can decide on the best route for you. I wanted to highlight that, and I thank you for giving women those options, because a lot of times, people are fearful of coming for evaluation because they think someone's going to tell them this is what you have to do and that's it. And that's not how it is. It should be really, you educate, you be the guide to the patient. And then based on where they are and their choices, together you decide on the path forward for them. One more question for you, Dr. Wayne. Dr. Wayne, so after the bleeding is stopped, and I feel like I can answer this question, but I want to ask you first, after the bleeding is stopped, what does life look like for these women?
Oh, I have seen so many life changes that I almost create a sense of expectation and hope when we bring the options to the patient. I did a hysterectomy on one of my patients. She had a good reason for having one. And as we were getting ready to do the surgery, I was kind of just happy with her, and I said, oh my gosh, I am so happy for you. And she's like, why are you happy for me, Dr. Wing? I said, because after we finish this surgery, your life is going to change tremendously. And I said, all this stuff that you've been telling me about is just going to disappear after this surgery. Yeah, there may be other issues that she has, but that bleeding's not one of them. And I think, I'll tell you another story. This is a story that I share with people all the time. I noticed that after I have an effective treatment, for the heavy bleeding, and it's working, and the patient comes back to see me for a follow-up. It happens so many times that they come in the room and their hair is all done up in a new style, and they have makeup on. The whole time that we were doing the evaluation, there's no makeup. They come into the office, they're wearing makeup, they're wearing beautiful clothes, and one of my patients, that she did that. She came into the office and I was like, "Oh, look at you, looking like you're going out someplace, looking nice." And we went through the evaluation, and I was talking to her, and then all of a sudden I went, "Oh," and she's like, "What's wrong, Dr. Wing?" And I'm like, "I see what you did today." And she said, "What? I said, "You are wearing a white pantsuit."
Yes.
And she broke out into tears. I mean, boo-hoo crying tears. And I said, what's happening? And she's like, I haven't been able to wear this kind of clothes in years. And, it was just such a, I was sitting there going, because that was just such a wonderful, life-changing thing. And, from your perspective and mine, just, seeing how that affects the mood and the outlook.
People come in and I know for a fact that when that, bleeding is gone, first of all, they get their lives back. They get the capacity to do more things. They have energy back. They're less irritable because now, they're not running on fumes. They're not worrying. There's a worry part about what to do about bleeding, but there's also the just running on fumes, and so being angry at everything, being irritable at work with the children, being short. They have their energy back. People start pursuing things that they've wanted to do that they've not had the energy just to do, because many times when people have heavy bleeds, all they're doing is going to work and managing to come back, and that's it. People are socializing more. People are, picking up new habits. Maybe they want to exercise. Maybe they want to do some social things. And so people are feeling much better. When I've sent someone who's anemic from a bleeding issue, to get treated, when they've been treated well and come back, they're a different person. Many times we are able to discontinue antidepressants because we've plugged the hole where it was leaking, and many times we unmask that this depression really was not, the main cause, the root cause of what was looking like depression this entire time was this bleeding, problem that they've now addressed. So it's a big thing, and I really want to thank you for taking the time today, Dr. Wing, to share with myself. I've learned a lot today for myself, but also myself and our patients, the importance, the intersection of periods, bleeding, and our mental health, and how to improve our lives overall by addressing this one problem. Thank you for being there for women. Thank you for the options you've shared today. Is there anything, last words, anything about you, one thing you want to share or leave with our listeners today before we go real quick?
I'm just excited, for our clinic that we have in our office. We call it the Heavy Bleeding Clinic. Nice, simple name. And the thing that's nice about it is that patients can come in and get this evaluation done, very concisely, very quickly, and then we can move to a treatment options in that patient. And I think the one thing that's great is that, the providers that work with us, all of the staff, they have the same heart that I have. And so what people have heard today is what they get in our clinic. I can't say that all of my doctor colleagues are that way. And I think, there are many of them that are very pushy towards hysterectomy as the treatment. And I just think that's a disservice to people. And so, for us, we've adopted this mindset, this way of, seeing and treating the patient. And I think that our
excellent. Where can people, so you mentioned you practice in Suffolk, where can people also find you online if they're looking to hear more from you or learn more about your work?
Sure. What they can do is they can go to our website, which is lifetimewomenshealth.net. And it's women's with an E. And I'll give you another link that you can put on the show notes, and that's a link actually to get on our
newsletter,
our mailing list, to receive more information about heavy bleeding and treatments.
Excellent. Thank you, Dr. Wing. That's it for today. Again, I'm Dr. And thank you so much for joining us. I'm Dr. Bolanle and psychiatrist at Bright Minds MD, a psychiatric practice in New Jersey. You can find me online at Dr. _Bolanle, that's BOLANLE on Instagram and TikTok. I'm also on Facebook with our practice at Bright Minds MD Live. It's been a pleasure having everyone hearing us out and talking to Dr. Wing today. Thank you for your time. Have a wonderful day ahead. Thank you. Thank you for listening. Don't forget to share this with a friend or two. Until next time, it's Dr. Bolanle on the Bright Minds MD and Your Mental Health podcast. Ciao.